everyone. I hope you're all having a good day. My name is Alfaisal and I'm honored to be your host for this webinar. I'd like to welcome you all to yet another exciting webinar under the Career Guidance Series United States Fellowship Track. So for those of you who don't know what Alfaisal MedHub is, Alfaisal MedHub is an initiative under the umbrella of International Office that aims at creating an online global community of medical students. Alfaisal MedHub covers a broad range of topics that are common to medical students all around the world. Our primary objective here at Alfaisal MedHub is to help medical students learn more about the career opportunities available after graduating, as well as the steps involved in pursuing them. So after conducting a series of webinars on the various milestones of the application process of pursuing residency in the US, we now hope to shed light on the various subspecialties fellowship pathways. Fellowship is the very next step of medical training after residency for many. And although there's a considerable knowledge among students and prospective doctors about residency, the journey from being a resident to becoming a fellow and consultant remains relatively vague. Hence, our series aims to guide medical students, graduates, and residents on this pathway and provide a guide to successfully matching into different subspecialties, making the process smoother. This series kicked off with a webinar on the overview of fellowship training pathway in the US and was followed by the first of the series of fellowship subspecialty-oriented webinars on hematology and oncology. Today, we'll be continuing this series and shedding light on the cardiology fellowship pathway in the US. Do stay tuned for updates on the other subspecialty-oriented webinars on gastroenterology, nephrology, surgical subspecialties. All of the webinars will be delivered by distinguished Alfaisal alumni who have successfully matched into their dream fellowship programs after residency. We're truly honored to have these renowned individuals who have embarked on an incredible journey throughout their careers on board with us to deliver these webinars. So with no further delay, I'd like to introduce you to our dear speaker for today, Dr. Mohammad Mathbout, who will be delivering the webinar titled Pursuing Cardiology Fellowship Training in the US. So Dr. Mohammad Mathbout is an interventional cardiologist at Norton Heart and Vascular Institute in Louisville, Kentucky. He's a graduate of the College of Medicine at Alfaisal University, class of 2018. Dr. Mathbout completed his internal medicine residency at the University of Kentucky. He completed his fellowship in cardiovascular medicine and interventional cardiology at the University of Louisville and the Medical University of South Carolina in Charleston, South Carolina, respectively. Dr. Mathbout is board certified by the American Board of Internal Medicine and Internal Medicine, Cardiovascular Disease, and Interventional Cardiology. He also holds the National Board of Echocardiography and Adult Echocardiography and the Board of Nuclear Cardiology. Dr. Mathbout's clinical interests include complex coronary interventions, intravascular imaging, and mechanical circulatory support. Thank you for joining us today, Dr. Mathbout. We're looking forward to this informative webinar. You're welcome to begin when you're ready.
Well, thanks for this generous introduction. We'll have the questions as they come, and we'll have a few minutes at the end to talk. This is going to be interactive. We're going to cover the application process for cardiology and its subspecialties, and then follow that up with some tips on how to do it successfully and how to sort of design your career path going forward based on what you value, what you need in your career, and how you envision your practice to be. So again, thank you for this introduction. So the agenda for this meeting is why cardiovascular medicine, why choose it to be, and if you go into into the residency application process, there's 1,001 options. Why choose cardiology? We're going to talk about the path, which is basically going to be a small conversation onto what is required to apply for cardiology fellowship and what goes on after. We're going to go dissect the fellowship application process, what matters, how to become a successful candidate. And then after you have successfully completed your 3 additional years of cardiology training, what advanced fellowships are there for you to pursue if you're interested in doing more training beyond your PGY-6. We're going to talk after that about defining your career, how to choose your job, which is again for PGY1s or final year medical students. This is 7 or 8 years down the road, but something to think about right now. And then we'll have a brief session towards the end to talk about, to see what questions you might have, to see if there's anything I could cover more in more detail. So without further delay, why choose cardiovascular medicine? It all comes down to what you like in your practice. For me, I get bored easily. So when you get bored, you want something that has a wide spectrum of practice. In cardiology, you practice clinical medicine in a med-surg level, going all the way to critical care. It is a procedural specialty, if you'd like it to be, meaning that if you're a proceduralist, you like to work with your hand, there's always the option of pursuing interventional training or structural training, or take it to electrophysiology, if you like, 4-hour procedures, or 6-hour procedures. If you're more of a sit down, kick back, and do your own reading, there is also the field of nuclear cardiology, CT imaging. Basically, it's the radiology of cardiology. If you see your practice involving the pediatric and adult spectrum of patients, then you could consider a congenital cardiovascular medicine, where you take care of patients from the age of 1 day old till they're 45 or 46 or 50. So it's again a wide spectrum of practice. You design your career based on what you like, and you could be doing more than one thing all at once. It's very intellectually stimulating, hence why cardiology. A big part of why I choose cardiovascular medicine is that if you like academics, it's alongside oncology, I would say they're the most rapidly growing fields of research. They have the most lobbying with regards to as a field of medicine. There's a lot of money that goes into research. There's a lot of academic opportunity that goes along with it. There's societies or the societies that support cardiovascular medicines that are very robust. I'm talking about the American Heart Association, the European Heart Society, the list goes on, the American College of Cardiology. They're very robust institutions. They're the motherships of every practicing cardiologist. So there is lots of opportunities for research and for academics. With regards to compensation, it should not be the main reason why you choose a field, but it's something that is definitely worth considering. Cardiology in general ranks top 3 in terms of compensation. And if you take it a step further into advanced cardiology, whether it's interventional cardiology or electrophysiology, that even makes it one of the top 2, if not the top, depending on where your practice location is. So it is very or relatively financially lucrative. In terms of lifestyle, well, this is somewhat of a counterpoint to why I choose cardiology. If you're an interventional cardiologist or into cardiology critical care, you're dealing with the sickest of patients. And that patient population could be a little bit stressful. So if you'd like to be on call your whole life once every 4 days, then these are career paths that you might want to consider. If this is not your cup of tea, then there's other options that are relatively less stressful. That includes non-invasive cardiology or clinical cardiology, cardiac imaging, heart failure, electrophysiology, and to a certain extent, congenital cardiology. So again, wide spectrum, financially lucrative, great opportunity for research and academics if this is what you're into. And then you could sort of gear your lifestyle or your career path depending on what kind of day-to-day stress or call you want to do. But there's practically whatever you want to do, it's there in this field. So as far as it goes for the cardiovascular fellowship application, this is for people primarily who finished their internal medicine training. When we talk about this, we're talking about a training path that starts after med school, goes into 3 years of internal medicine, and then you go into a 3-year additional of cardiology, and then to follow with advanced fellowship. But that being said, To apply for a fellowship in cardiovascular medicine, what you need is 4 letters of recommendation. After you have completed your internal medicine residency training, the fellowship application cycle starts in the last year of your internal medicine training, or 4th year if you've gone through the medicine or PED-MEDS pathway, where you've done pediatrics and medicine simultaneously. You will need 4 letters of reference. I say here 3+1 because one of these letters should come from your program director at your internal medicine residency program. And the 3 remaining ones you allocate however you like, but having sat on the other side of the fellowship, on both sides actually of the fellowship application process, I would say that 3 out of the 3 remaining ones should come from cardiologists in your institution. The research and academic profile play an important role in cardiology applications. It is a relatively very competitive fellowship. So the more robust your academic profile is, the better you've done in your during your residency, the more academic meetings you've attended, whether it's ACC, SCI, AHA, you name it, CRF. The more robust your academic profile is, the better your chances are at landing a spot in a program of your desire. You have, when it comes to choosing your program, obviously they have to choose you, you have to choose them. But what I would say is that it has to be geared towards what you want to do. If you want to do an imaging guided, research driven kind of fellowship, then you have to go for those programs. If you want to do a procedural fellowship, then your sub-fellowship after that, then you're probably better viewed off towards a university program that has a large area of catchment for procedures, so that you get all these patients and you get hands-on more during your training, because you learn your interventions, you learn all of that during your general training, and then you kind of tip it off once you've done your advanced fellowship. So know exactly what you want after you're done. And some people say, you know, all I want to do is just be a non-invasive general cardiologist, and that's great, at which point your options for programs sort of is wide open, because every single program that is accredited by the ABIM is geared towards giving you that kind of training. So in terms of what you see highlighted here, cardiology or cardiovascular medicine, is a very small world. Everybody knows everyone, and word travels fast. So make sure that whenever you attend these cardiovascular conferences or meetings, that you get to meet people, put in your best face forward, interact, make connections, present yourself well, because you never know where opportunity presents itself. Often I met one of my program directors in a meeting, and this is how I ended up in a fellowship, one of the fellowships I've done. So all I'm saying is that it's a very small world. Make sure that that your reputation precedes who you are. That's going to translate in the letters you get, and the academic activity that you've done, and in the personal one-on-one connections that you build over your years of training. That being said, mentorship matters a whole lot. So whatever you end up in training and residency, find a cardiologist who's active, who likes you, and who's willing to mentor you, because that cardiologist, I could assure you, he knows 100 other cardiologists who are capable and able, capable of helping you get what you need. So to sum it up, basically, you're going to need 3 years of internal medicine, 4 letters, a decent of reference, a decent research and academic profile, and signs of life, academically speaking, attending conferences, presenting, doing case reports, whatever you could to get this application going forward. So having started your fellowship, we'll talk about the fellowship in later detail, but you know, as you come closer to finishing your fellowship in cardiology, a few doors start opening up for you, and more questions pop up. Are you going to do a general cardiology? kind of career where you see patients at the hospital, you see patients in clinic, and then manage them clinically. And then whenever something that needs to be done from an interventional or a sort of procedural focused standpoint, you're sort of the gateway towards other advanced practitioners or providers. Or you don't want to do that. You don't want to be the gatekeeper, but rather you're more interested into gearing your career towards a specific niche in cardiology. And under cardiology, as we've talked or mentioned earlier, there's a number of subspecialties that you could consider. In red here, I've highlighted the procedural ones. So interventional and structural cardiology are sort of the procedural field, the surgical fields of the practice or the fellowship. This is a very rapidly growing field that focuses on interventions that are coronary interventions, stents, valve procedures, like aortic valve replacements, mitral valve procedures, clipping, structural heart interventions. It also focuses on mechanical circulatory support in patients who have heart failure. It also focuses on peripheral interventions, basically leg interventions and carotids and any other vascular bed other than the heart. It's again, like I said, it's a very rapidly growing field. It's very robust, and it's the kind of field that comes in with some pay in terms of I'm not talking financially, but again, it tends to be a little bit more stressful. There's a little bit more call. It is very rewarding. There's instant gratification. Doing interventional and structural cardiology, it's a 1 to 2 year fellowship. Usually only the first year is accredited. The second is an optional year. The application process for interventional cardiology starts in the second year, which is a bit odd if you compare it to every other application process. So it starts 1 year earlier than every other fellowship or residency. In your 3 year of cardiology training, your interventional cardiology application goes out in the second year. And you have 1 year sort of latency before you're able to start training. At the end, once you have completed the first year of training, assuming you're going to go for 2, you're qualified or you're board eligible to sit for the American Board of Interventional Cardiology. The second year, the structural cardiology, again, is a non-accredited fellowship that people do to sort of gain more experience should they desire. Electrophysiology, it's the study of the electrical conduction pathways in the heart. It is a procedural specialty that focuses on ablations, pacemaker, basically anything that is electrical in the heart. It's a 2 year fellowship that starts after completing 3 years of internal medicine, 3 years of general cardiology training, and then 2 years of electrophysiology, which by the time you've completed your training, you're a PGY 8. Add that to the 6 or 7 years of medicine or med school that you've done. So it's a 2 year application or fellowship. The application process, again, is typical. It starts off in the 3rd year of your general training. Adult congenital fellowship, and I have an asterisk here because again, this next to it, because this pathway you don't have to go through internal medicine to be an adult congenital cardiologist, but you could do a med peds or a pediatric cardiology or a pediatric residency followed by pediatric cardiology, and then find your way into adult congenital fellowship. And this is basically a field that is concerned with patients who are born with congenital abnormalities and their heart and vascular beds. It tends to be interventional in a way, but often adult congenital cardiologists work with interventional cardiologists simultaneously in a pre-designed elective procedures to correct whatever anatomy that is abnormal. It depends on where you do your fellowship. It varies, but it could be anywhere between 1 and 2 years. Advanced imaging and advanced heart failure and as well as cardiology critical care, all of these 3 fellowships are a 1 year fellowship. So by the time you've completed your training, you are a PGY 7. Advanced imaging focuses on CT or computed tomography of the heart, CTA. It also focuses on cardiac MRI imaging, alongside other forms of imaging, but that's the main focus when you say advanced imaging. You're talking about CT and cardiac MRI. It is a 1-year fellowship, and those people are basically the radiologists of cardiologists. They do everything else the medical cardiologist does, plus read these advanced modalities of imaging. Advanced heart failure, this is again a 1-year fellowship. Recently or will be soon accredited by the American Board of Internal Medicine as its own board. It has a, when I say accredited, I mean it has a test at the completion of the fellowship that runs every other year, if I recall correctly. The focus of the study is advanced heart failure. We're talking about being the gateway towards heart transplant, working very closely with the cardiothoracic surgeons, and also they're the gateway towards mechanical circulatory support that is surgically implanted and indwelling permanent. We're talking about left ventricular assist devices, right ventricular assist devices, and so on. There is a bit of an overlap in the advanced heart failure practice with cardiology critical care in the inpatient setting with the temporary ventricular assist devices like ECMOs or Impellas or any of the devices that are implanted in these very sick patients during periods of heart failure or severe LV or RV dysfunction. This fellowship is 1 year. Its board runs every other year. And again, the application process often starts in the 3rd year. It is not a typical application process in most programs, meaning that you reach out directly to a program that you're interested in and see if they have positions that are available, and then talk with them about to see an interview with them to see if you're a good candidate for that spot or not. Cardiology critical care is an emerging field that focuses on caring for patients in the coronary critical care unit. And it is a 1-year fellowship that follows your general training. At which point you're going to be the critical care physician with a strong background in cardiac care. It is also, its board is really a critical care board that you complete after, or you sit for after completing your cardiology training. Of all of these pathway or applications, usually you always need 4 letters, 3+1, the last one being from your program director. Electrophysiology is a standard match process, whereas interventional and structural cardiology, it's not you apply through a match-like process application, but when it comes to matching, there is no match, meaning that there is no ranking. It all comes down to you go in an interview, you hit it off with the people who you met, seeing that your goals align, and then they offer you a job. It's a job offer. Something very similar goes along for advanced heart failure and advanced imaging. So of the entire list that you're looking at, only cardiology critical care and electrophysiology go through a standard match process. The rest of these advanced fellowships are more of a word of mouth, than not word of mouth per se, but rather you go on an interview and then you get a job offer. That being said, defining your career. Once you've done all of that, and it's definitely something that you should have thought of along the way, where do you see yourself practicing? Do you see yourself teaching residents, teaching fellows, being a part of an academic institution, or that tends to be a little bit more of a slower pace kind of practice, but rather more academically involved per se? There's also the private scope of practice where it's a more robust, more rapid, again, focused mostly on clinical patient care, less so on research and teaching. Or there's the mixed pattern, which is a very common theme that you see in cardiology, because most of the patient population that you see is actually controlled by private institutions rather than by academic ones. And the vast majority of academic centers have some sort of affiliation with a private center that has this patient population. At which point your focus will be large volume patient care, but at the same time, there is some sort of academic components, whether it's research, whether it's teaching, fellows and students and residents from affiliated academic centers. So this mixed pattern is very common in cardiology. Again, private office space is also there, and then purely academic cardiology is there. Interestingly enough, once you are an electrophysiologist or an interventional cardiologist, even if you are in a purely private setting, there is often research opportunities. Again, if you think about research in this field, it's largely driven by patient volume. And if I tell you patient volume predominantly exists in private settings, then device companies, drug companies are going to come to you to be part of a large cohort of patient trials to enroll your patients in these studies. So even if you're purely private, more often than not, you're going to be able to conduct or be part of large research trials that are driven by pharmaceutical or device companies. Now, when that again comes back to how do you want your career to be? Do I want to be on call is a big question if you are a cardiologist. Most fellowships, and this is something that maybe I did not highlight enough, whenever you are in cardiology training, you're going to be on call. This call is about 60 nights your first year, 60 nights your second year, and virtually no call the third year. But it could be different depending on what program you're in. If you don't mind being on call, then interventional cardiology is the way to go, because you're going to be on STEMI call caring for the sickest of patients at 3 in the morning, once every third night or fourth night or seventh night, depending on where you're practicing. If this is not your cup of tea and you want to do procedures, but you don't want to be called at 3 in the morning, then electrophysiology maybe is the way to go for you. General call is present. So if you're a non-invasive cardiologist, you will be on call overnights, but in most places, you're not really having to come into a hospital, but rather managing things remotely. If you don't want to be on call, period, and you want a 9-to-5 job, where you see patients at the hospital or in the office and then go home and turn off your pager or turn off your cell phone, then these models do exist, maybe in fields like heart failure or even non-invasive cardiology or advanced cardiac imaging, or other fields really. Like even if you're an invasive cardiologist, not an interventional cardiologist, but again, these jobs come a little bit, tend to be a little bit more rare. It comes down to where you interview and where you see yourself practicing. This is a big component. Do you want to be on call or not is a big question that you should ask yourself every year as you go through with your cardiology training. Do I like critical care is another big question. Are you and this is something that you have to know yourself, and this is something that you're going to develop a sense of as you go through your internal medicine training and as you go through your cardiology training. Are you someone who thrives on high risk, high stakes situations, or are you more of a person who likes to kick back, think things in a clinic settings where you're more interested in chronic management of problems than in acute exacerbations of these problems? That kind of determines what kind of career path, what kind of sub-fellowship training you might be interested in pursuing. Do you like research? And this ties back to what kind of setup you want to be in, academic, private, or a mixed setting. That being said, you have to keep in mind that the overall compensation pattern for cardiovascular medicine, and unlike many other fields, it tends to be usually more lucrative in private and mixed settings, and there's less financial incentive in joining academic institutions. Again, this varies, but this is just an overall theme of how things are. And again, before you choose cardiology, you have this is the hallmark between a good cardiologist and not so good cardiologist. Big difference is that it's a very rapidly changing field. There's a new drug, and this is driven again by how much research and research money is going into the field. If you want to be a good cardiologist, you always have to be well-read. Knowledge is going to be changing on a daily basis. New procedures, new drugs, new techniques, changes in the guidelines happen on a yearly or bi-yearly basis. So a good cardiologist is someone who keeps up. A not so good cardiologist is someone who anchors to whatever they learned and to what they've learned previously and become stagnant in their knowledge. So it's a rapidly changing field. If you're interested in that, if you're interested in reading, staying up to date, staying in touch, then this is the field for you. If not, then I don't know what to tell you. So basically, that sums it up. These are the talking points. Now we'll leave it up to the people here to see what questions they may have and what things I could help with.
Thank you very much, Dr. Mohammad, for this very informative presentation. It was great to learn about the different advanced fellowships in the field of cardiology. So thank you again for sharing this very valuable advice with us. And I'm certain everyone found it just as beneficial as we all did. To everyone in the audience, thank you for joining us for this webinar. Guys, if you have any questions for Dr. Mohammad, feel free to unmute yourselves or just put them in the chat box.
Okay, hi, thank you so much for the presentation. I really loved all the information you're dropping there. I don't know if you answered this or not because I kind of joined in a little bit late. I'm sorry about that, but let's say a person's very interested in interventional cardiology. In terms of research, do you have any advice on what kind of papers we should be pursuing? And is there like a specific list of how many researches we have to get published if we should be considered for the career? Or is it more of like just, you know, connections, some people who might know you might want to get you in, even if your research isn't that good?
All right, that is a very good question. So it's not really, it doesn't really come down to how many papers you have out. It all comes down to showing signs of life, academically speaking. In your med school years or residency, the same concept goes through, which is try to get your hands on case reports, interesting cardiology cases that you might be able to publish. If you're able to partake in any local or patient enrollment for a study of whatever sort, if you would hang out with your echocardiographer over at the hospital and get a good letter of reference later on, that might help you get you connected to some sort of a research lab or whatever it is. What matters, and then during your med school years, if you are capable or able to attend any of these research meetings or conferences, all of that shows strong interest, and that matters when you apply. I wouldn't say that you need 10 papers or 15 papers to be able to apply for a cardiology fellowship. I would say that's just showing signs of interest and ability, and then academic interest per se should be sufficient. The other part of this is finding mentorship. If you have a mentor who you're connected with early on, often this goes a long way because these people know people. So connections do matter. So I don't know if that answers your question.
Yeah, that helps a lot. I thank you so much for answering. I really appreciate it, and I really enjoyed the presentation as well. It was wonderful.
Absolutely.
Thank you so much for your presentation, Doctor. I have a question more about like after fellowship, how are you finding like the lifestyle in general, being like an interventional cardiologist? Are there ways around where you get to choose your schedule where it's not too hectic?
It is a good question. It all comes down to where you want to practice. There is always a way. So what I'm doing, so I work at a Heart and Vascular Institute that's got large volume of patient population. There is a high STEMI volume that occurs, and then there's about 12 other interventionalists in that practice. Yet at the same time, I'm on call every 5th to 6th day. So if you are looking to be an interventional cardiologist, but you are trying to find sort of an easier career, career design, it is possible. Most of these jobs occur, at least here, in rural areas where they just are looking for somebody to do elective work, but they're not really a STEMI center. It kind of takes away from how rewarding the job could be. It definitely adds a lot to how comfortable it is. I personally, well, I'm still 33, so I don't mind the call. I find it interesting. I don't mind being woken up at 3 in the morning to do something that is relevant. Are there jobs for interventional cardiologists or that are easier in terms of call? Yes, there are. Are they more rewarding? Often not, and they tend to occur in smaller towns where hospitals are not designated STEMI centers. So basically your cath lab or your procedural suite goes to sleep at 5 o'clock and wakes up tomorrow at 7. These jobs do exist, but I find choosing interventional cardiology with the thought that I don't want to do this after might be a waste of a year or two. And again, this is personal perspective.
Yeah, but you just said something like, so now you don't mind waking up at like 3 and stuff, but what about like in the future?
Right. Some people opt to not take call after a while, but that's, again, that takes away from the practice. Most interventional cardiologists I know are still getting woken up at 5 or 4 in the morning, and they're in their 60s. So some people revert back to a standard kind of calls or like work setup or work schedule. But again, you're not really that interventional cardiologist anymore, right? The cornerstone of the practice is call, unfortunately, but it is. And you could be taken off of the call pool, meaning that you only do elective procedures, but that will impact your procedural volume, your referral base, your ability to find patients. So it would drastically alter your practice. Now, if this is the kind of practice you're interested in, that's something.
All right.
But it drastically changes your sort of job description.
Yeah, I totally understand. Thank you so much for your presentation.
I'd like to ask a second question, if that's okay.
Sure.
What I've been reading is that generally most cardiologists, they get hired from the same institute that they did their residency at. So do you think that we should be, like as students, we should be applying specifically to hospitals that we know have cardiology programs? Or do you think it's okay if we can switch between institutes like post-residency?
So that's an excellent question, actually, because you're partially right. And again, by design, if you're interested in cardiology training, it's a competitive field, and often institutions favor their own applicants. So that's meaning what I mean is that if you've done residency program X, then you're more likely to go into cardiology fellowship at program X, and then advanced training at program X at the same time. It goes with, it kind of goes without saying is that because of the competitive nature of the specialty and its subspecialties, going into a community program in residency might complicate you landing a good spot for cardiology training later on. I'm not saying it's impossible, I'm saying it complicates things. So if you know from the get-go, you're a medical student in your final year that you want to do cardiology, then my recommendation would be in your residency application process, focus on at least mid-tier university programs. And then find your way from there. Stay away from community programs that do not have dedicated specialties. So yes, that doesn't only complicate you landing a spot in your own program, but also landing a spot anywhere, because we did having been on both sides of this application process, we do filter largely applicants based on what institution they come from during the interview process. So yes, try to land a university program, and preferably for residency, and preferably one with a cardiology fellowship that you'd be interested in. Now for a career, that's kind of different, because you could do your training anywhere, and then the job market is wide open. It's much more comfortable to stay in the same area where you trained at, but doing training anywhere in the country would, it should not complicate finding a job anywhere else in the country.
All right, thank you so much.
Absolutely.
I hope I'm not hogging the mic from anyone, but this is more of a hypothetical question. You mentioned that cardiology is a rapidly evolving field and there's constantly new research and new techniques being developed, right? Do you feel that with the advent of AI and ChatGPT, it's going to have some big impact on the industry?
AI might actually impact, well, actually, this is a good conversation. AI might impact non-procedural cardiology, meaning that it might impact advanced imaging, mainly actually advanced imaging, because a lot of these, like the way it would impact radiology, right? Because a lot of these scans and studies would be automated and read by AI and then verified by a physician. So a lot of these institutions are not going to need 3 or 4 cardiologists treating, but rather one AI and then one cardiologist to verify and make sure these readings are appropriate. Do I think this is going to happen in the next year or 2? Probably not, but down the line, 10, 15 years, I'm not an AI expert, but I wouldn't be surprised if that was the case. In terms of procedural specialties, I think this is a far-fetched like future. If you look at robotics and interventional cardiology, it's the whole. I train in robotics, and the whole setup is still in its infancy. So even with your robot in place and you're doing the procedure from the control room, you still need a technician inside who's loading your catheters, loading your stents, and the whole setup is not nearly ready. And I do not foresee it being ready in the next 10, 15 years. So I hope that answers your question.
Thank you so much. I love the answer.
Okay, so I don't think there are any more questions, Doctor. Thank you, everyone. Please make sure to register for upcoming webinars under both the Career Guidance Series US Residency and Fellowship Series. You guys can scan the QR code for the registration link. Also, make sure to follow us on Instagram and Twitter and subscribe to our YouTube channel to receive the latest updates about all our upcoming events. And just before we end, I'd like to share with you a few links that will lead you to Alfaisal MedHub social media platforms. So thank you, Dr. Mohammad, and everyone in the audience once again, and we hope to see you all again in our upcoming events.
Thank you.
Thank you so much. I really appreciated the lecture.